Hello. Today I will talk about general approach to abdominal pain. First, identify patients requiring resuscitation or urgent treatment. The need for resuscitation is apparent in emergencies with associated hypovolemic and/or septic shock. Less obvious, but equally important, is recognition of patient requiring urgent treatment with no clinical evidence of shock, especially ruptured abdominal aortic aneurysm. Now, I will talk about important notes in the history. 1. The pain. Determine details of site, severity, radiation, shift, character, timing, precipitating and relieving factors. 2. Vomiting. Ask about the nature of vomit, blood or bile. Vomiting that follows the onset of abdominal pain tends to imply a surgical cause, whereas vomiting preceding pain is often non-surgical. 3. Bowel disturbance. Inquire about recent change of bowel habit, particularly in erectile bleeding. Do not forget that the abdominal pain may be due to urological, respiratory, cardiovascular, or gynecological disorders. Also determine the nature of previous surgery.
Now I will talk about examination. 1. Vital signs: pulse, blood pressure, respiratory rate, oxygen saturation, Glasgow Coma Scale, and temperature may indicate the need for immediate intervention. 2. Abdomen. Note distension and old scars. Check hernial orifices. Palpate gently for areas of tenderness. Tenderness on percussion is ample evidence of peritonitis. Also perform PR or PV examination only if necessary. 3. Look for evidence of dehydration and jaundice. Examine the respiratory and cardiovascular systems.
Assessment of patients with abdominal pain and ED usually depends on history and examination rather than tests. However, the following investigations may prove useful. 1. BMG, because DKA may present with abdominal pain, like in hyperglycemic crisis. I will talk about it in next videos. 2. Urine analysis. Abdominal pain may result from urinary stones or infection. Perform a urine pregnancy test on all women of childbearing age. 3. Blood tests. Consider liver function tests, CRP, coagulation screen, amylase, ABG, lactate. 4. ECG, especially in patients aged greater than 55 years, who may suffering from atypical presentation of acute MI. 5. Erect chest X-ray. It can help to exclude chest pathology which mimic abdominal condition, such as congestive heart failure or basal pneumonia. And it also reveal free gas under the diaphragm. 6. Abdominal X-ray. Specific indications for abdominal X-ray include suspicion of intestinal obstruction, toxic megacolon, sigmoid volvulus, and GI perforation. X-rays are not indicated in patients with suspected uncomplicated appendicitis, UTI, simple constipation, gastroenteritis, GI bleeding, and acute pancreatitis. In severely ill patients, requiring imaging CT or ultrasound is usually more appropriate than plain X-rays. 7. Ultrasound. It reveals gallstones, free peritoneal fluid, urinary stones, and aortic aneurysms. 8. CT. It may have a role in assisting with the diagnosis of certain conditions, such as acute appendicitis in less straightforward cases.
According treatment. Prompt resuscitation and provision of analgesia are integral components of the management of serious abdominal conditions. Ensure that patients who are very sick and/or hypotensive receive early IV fluids, but caution if aneurysm suspected, and full monitoring, including measuring urinary output by a urinary catheter.
The traditional belief that analgesia should not be given because it might mask a serious diagnosis is incorrect. Diagnosis is often easier when pain is relieved, and the patient can give a better history and cooperate with examination. Steroids, non-steroidal anti-inflammatory drugs, obesity, may render physical signs less obvious. In elderly patients with peritoneal inflammation, a lack of abdominal musculature may make it difficult to elicit gargling. Beta blockers may mask signs of shock.
Absence of fever does not exclude infection, especially in the very old, the very ill, and the immunosuppressed. When severe abdominal pain is out of all proportion to the physical findings, consider mesenteric infarction, aortic rupture or dissection, acute pancreatitis, and torsion of ovarian cyst. Splenic rupture may occur after relatively trivial trauma, especially in patients with glandular fever or hematological disorders. Consider gynecological causes of abdominal pain in any woman of childbearing age, so always perform a pregnancy test. White cell count may be normal in established peritonitis or sepsis. Amylase may be normal in acute pancreatitis. Conversely, moderate amylase elevation may occur in acute cholecystitis, perforated peptic ulcer, and mesenteric infarction.
Thank you for watching. In the next videos, we will talk about surgical causes of abdominal pain, so please subscribe the channel to see more. Goodbye.